Hi, Susan. Can you hear me? I can't hear you. Oh, there we are.
Good morning.
Good morning. All right, we're all good and I can see your camera. I'm looking, there's another Susan joining us. All right. So to remind everybody, our guests, our attendees can in fact see and hear us right now. So they're getting a little peek behind the curtain, but my point is don't say anything you shouldn't. All right, so Susan, you're all good to go. Give me a 1, 2, 3.
1, 2, 3.
All right. Are you on a phone, Susan?
I am, because my computer is.
Okay. Can you turn it
I can
sideways?
use.
Can you turn
Turn
it
it
sideways
sideways.
for us?
Oh, okay. Is that better?
No, that's
No.
weird.
Okay, I'm gonna go on my computer then. It's just gonna be a
That's
little
okay.
pixelated on my computer.
That's okay. If
Okay.
if the computer won't work, we'll go with this. All right. So I am going to turn everybody off. We need to well, I guess we could wait for a minute to start the pre-video, but all right. So I'm going to turn you all off so you can get comfortable, and when the music ends and the slide ends, that'll be the time for you all to turn on your video and microphone and begin. So I'm gonna turn this off right now.
Okay.
Good afternoon. Welcome to our 4th year of behavioral health around the state events. We are so delighted that you're taking your time to discuss this important issue to Louisiana and around the state. We are thrilled to have some wonderful panelists with us today, and wanted to start with if you were a watcher of 60 Minutes, you've already seen a whole lot of conversation about where Louisiana ranks in the United States on maternal health, physical health. We are in fact exceed the national average on maternal mortality. But today we're going to talk about another side of that. And certainly the physical and the mental cannot be separated. They are connected to one another, and our fabulous panelists are going to talk about that. But we're going to really focus today on maternal mental health. Here with us today, we have Dr. Rochelle Dunham. She is the executive and medical director of, and I think you're one of the few that have both that title, right? Dr. Dunham with our local governing entities at Metropolitan Human Services District. Dr. Dunham is also the endowed professor and an endowed professor at LSU School of Medicine and an addiction psychiatrist with academic appointments as a clinical associate professor and clinical assistant professor of psychiatry at LSU and Tulane University Schools of Medicine. Her past immediate appointments were assistant secretary and medical director for the Office of Behavioral Health within the Louisiana Department of Health. In that capacity, she represented the state of Louisiana nationally as the Mental Health and Addictive Disorders Authority, serving as both the Commissioner of Mental Health for the National Association of Mental Health Program Directors and the single state agency director for the National Association of Alcohol and Drug Abuse Directors. I could go on and on about Dr. Dunham and all of that she's accomplished, but one of my things that I most admire about her, and I know that she's going to bring some of this into the conversation today, is that she's a lifelong learner, and she keeps going for information and sees problems and issues in our state and beyond, and wants to get to the core of them, and does. And that always really impresses me. I don't think I've ever had a conversation with Dr. Dunham where she wasn't in some sort of school or class or program learning something else about what is happening in our community and how it impacts the mental health of all of us. Joining Dr. Dunham today, we have Melanie Richardson, who is the co-founder, executive director, and director of parent learning for Training Grounds. Melanie is a native New Orleanian who has been working in the fields of mental health and education for over 20 years. She received her undergraduate degree from the University of Notre Dame and her master's in social work from the University of Pennsylvania, and a specialist in community college teaching from Arkansas State University. Melanie is committed to educating families and professionals and removing institutional disincentives and impediments, barriers to increase the academic success of minority and low-income students. And she's going to tell us more about her work at Training Grounds in New Orleans. So ladies, and Susan Henry is going to be our lovely host today and help direct some of the questions and this important dialogue. And I'll be back to answer any of, or to direct any of your questions. So members of the audience, if you have questions for these ladies as we go, please put them in the chat box. And we will answer those questions when we come to that portion of the event.
Thank you. Sorry, we're gonna put questions in the Q&A box.
Thank you, Amanda.
Q&A, not chat.
Yes, not chat. So sorry. We're going to put questions today in the Q&A box. We'll take them there. Please put them in as you think of them. We'll address them there.
What's that mean?
All right, Susan, take it away.
Hi guys. Sorry I'm not a face today. Well, good afternoon, everyone. Thank you for joining us. We have an important topic to discuss: maternal mental health. Let's begin by taking a closer look at the data figures that shed light on the challenges many mothers face. Dr. Dunham, can you provide us with data that will help our audience better understand the scope of the issue and the urgency of finding effective solutions?
Absolutely. So first I want to say good afternoon to our audience, and thank you so much for taking your precious time to come and meet with us today, because we are sure that the information we'll share will minister, if not provide just a wealth of information to those of you who are women in our community. And so the data doesn't look good, ladies. And so it's of concern to us that it does not look good. And on the screen, you'll see some of the stats that we have been able to garner for you for today. We did a lot of research in preparing for this presentation. And the nice thing about it is that we have gotten a lot of affirmation on the information because a number of different sources report the same thing. For example, you will find that 1 in 5 of people who are pregnant and in a postpartum period suffer from maternal mental health disorders like postpartum depression. It also is something that people don't like to talk about, unfortunately. Women are embarrassed, they feel inadequate, especially if you're a new mother and you really don't have any affinity for your child, or you're not able to bond to your child. That's a very uncomfortable, unnatural place to be in, and yet it is a very familiar place for a lot of women. 1 in 5, less than 15% though, receive treatment. In fact, of the women who have problems with depression or mood disorders, 75% of them don't get treatment, whether they are in a pregnancy state or not. The other thing is 1 in 4 will experience depression during pregnancy. And 56% of those living in poverty experience postpartum depression as well. Now, more than 600,000 people will suffer with maternal mental health during any course of every year. That's a lot of people, and almost half of adolescents struggle with their mental health. And those numbers tend to be worse in adolescents if in fact they are pregnant. There is a whole lot of issues here for the family, which we will go into, but we don't want to miss the situations that occur with men, which Melanie will talk a little bit more about that. And we also want to make sure that we pay special attention to the fact that the rates of depression are more than double in Black populations due to the cumulative effects of stress, weathering. I want you to note that mental health conditions account for 9% of pregnancy-related deaths, and suicide accounts for 20% of postpartum deaths. And a lot of the time, deaths in women have to do with overdosages with substances. So the whole substance use interface here is a part of the mental health crisis we have with women. And over 50%, I mentioned, of people who are depressed during pregnancy are untreated. And in 2019, maternal mental health conditions were the leading cause of pregnancy-related deaths. Melanie?
And Dr. Dunham, I want to go back and visit when we talked about the rates of depression are more than doubled in the Black population because of weathering, right? This concept of weathering and really kind of taking into consideration all of the stressors that Black women have to deal with before and during their pregnancy. And because we know that there's such a large amount of mental health illnesses and depression and stress related just from environmental conditions, as well as just the idea of becoming a new parent and the relationship stress that comes, we see that this population is really having some negative outcomes when we talk about maternal health, whether it is the postpartum depression or maternal health outcomes for both them and their baby. And we'll talk a little bit more about the impact of postpartum depression or perinatal depression on the outcome of children as well. And I would be, remiss if I did not mention that men as well, like that is a population that we really don't talk a lot about, but 1 in 10 men actually suffer from postpartum depression as well. That is something that is talked about even less than the women and those women that are dealing with postpartum depression. So as we go through, we'll talk about as well, what does it look like for men that are dealing with postpartum depression? Because we know that when women deal with postpartum depression, there's a higher percentage that the men will deal with some type of depression as well. And we can only imagine what those impacts would be for children who are having both parents dealing with depression during this critical time of bonding and attachment. So thank you, Dr. Dunham.
Thank you, Melanie. And I want to also emphasize too to the audience that a lot of what you'll hear are comments relative to that prenatal period for the woman, but we are talking about peripartum, prenatal, the natal period prior to pregnancy. So just the natural course of women, and mental illness and psychological difficulties that are experienced that are unique to women because of a number of factors. So we will be reviewing that as we go through our discussion here.
Well, thank you for those facts. That was very eye-opening. Moving on, we're going to move on to nutrition. Let's explore the profound impact of nutrition during pregnancy on the health and development of the fetus. Dr. Dunham, to kick off our discussion, can you provide some medical insight into the science behind the ways a mother's dietary choices play a pivotal role in shaping the well-being of the growing life within her?
Yeah, this actually is another one of those subjects that I have done some extra learning in. I did a 10-month course in nutrition, just completing that course and looking to get some certification there, simply because the importance of food is so underrated in terms of how we can manipulate and manage what we ingest to control our overall health, not just our physical health, but also our mental health. And we just don't have a lot of data around that, but people who are functional nutritionists, they know this information very well, and they are very advisory in their role as clinicians or healthcare providers in the people that they serve. And so it just does us a huge service to consider the impact of food and nutrition in our thinking about how a person's, not only their physical health, but also their mental health is impactful. So let me just share some thoughts with you. First of all, there are several basic components to good nutrition. The first thing is that nutrition or health as a result of what we're ingesting begins with the mouth. It's the first part of our digestive system. And you may say, well, you know, that's logical. But what you probably are not realizing is that how much and how well we chew our food makes a tremendous difference in terms of how well and how much we absorb the nutrients from our food. So for those of you who are fast, rapid eaters, you are really not maximizing on the benefits of the nutritional items you are putting in your body, even if you do go to Whole Foods and spend a whole bunch of money on it. If you're not chewing it properly, you're not allowing it to be broken down to its lowest chemical components, so that the enzymes in the mouth and in the stomach and in the intestines can do their work on it to extract from it all the nutritional value. So people who do this work will tell you that you should chew until you actually have liquid in your mouth, no matter what you're eating. Now, obviously, meat is a different category if you want to liquefy food in your mouth. So what about meat? So all meat is not healthy. And so that's why you hear so much about eating a whole lot of beef or eating a lot of dense red meats or meats that are just dense in general, because it's really hard for the human body to digest those products and to therefore extract all of the nutrients from them. The things that are easiest to chew and break down to its simplest component are fruits and vegetables. And on to fruits and vegetables, it's important to know that variety is the spice of life. And so look, I'm not going to tell you about all of the different nutrients that you can access by eating certain types of foods, even though there are some things that are very, very important in mental health, like the B vitamins, for example. They are very important to memory, concentration, cognitive functioning, higher level functioning. That's important in dementia. That's important in depression, to be able to think clearly. They're also energizing. So one of the problems with depression is that people are apathetic. They don't have a lot of energy. They don't have a lot of motivation. Some of that is just fatigue and not physically being as healthy as the person needs to be. There's a need for calcium, iron, folate, all of those substances need to be ingested and removed from foods in order for us to have full balance. But a lot of those things, macronutrients, micronutrients. Macronutrients are the proteins, carbohydrates, and the fats. But the micronutrients are the calcium, the iron, the selenium, the magnesium, all those things that come packaged very beautifully in nature, in plants and vegetables. And so my recommendation to you is you really should eat the rainbow of colors. You don't have to know what is in each particular fruit or vegetable. You can look that up. But if you're adding variety to your diet so that each meal you've got some different colored foods that you're ingesting, then I can promise you that you are on your way towards balancing. And many people who do this kind of work, that's what they'll tell you. It's not important that you know all that detail, but it is important that you know that the variety of foods and the types of foods you eat are going to be your best bet. And the beautiful colors of food predominantly exist in plants and vegetables. And that's why at least 2/3 of your intake daily should be fruits and vegetables. And we should be lower on the side of meat. And we do need some carbohydrates. So that's a fallacy that you shouldn't be eating carbohydrates. Stay away from white. White anything for food is not a good thing. So white sugar, white bread, white potatoes, all of that stuff. Get the color. The sweet potatoes are orange. That's why they're better, because that orange has a whole nother different thing going on with it. So make sure you add color. The other thing is food insecurity is a problem, therefore. And we're going to talk a little bit more about that. Melanie's going to go into some of that. So, but food security is critical. I'm telling you, you have to eat the rainbow. You got to have it to eat it. And if you don't have it, then you are sacrificing health, mental health and physical health. And then finally, the other thing I want you to know is that in the nutritional world, there's a lot of emphasis on the concept of food, mood, and poop. Now, you know, that may sound kind of strange, but you need to be paying attention to what's happening on the other end, because what's happening on the other end is a good indicator of what you're putting in that may or may not be appropriate. And so the other thing is our mood impacts our digestion and our digestive system. And so constipation is not a secret that there's some problem going on there, but diarrhea is a problem as well. And it has to do with what we're ingesting, both environmentally, what we're taking in, as well as what we're taking in internally in the form of food. So awareness of how these things are connected and how we tend to eat differently depending upon how we feel. Many times when we're overwhelmed, we are more likely to pull for the potato chips or pull for the sweet candy, the simple sugar candies or whatever. That's an indicator too of what our mood state might be that is impacting our physical health. And when we eat these things are digested in a way that they add balance so that we can have a normal mood. They are perceived as ways of addressing our stress perhaps, but it doesn't do anything but compound the problems that we are dealing with. So all of these things are important. So since the mother is the host, the child is growing inside the mom, then the child is a passive victim of whatever that mother is ingesting. And so if that mother's ingesting the rainbow, then that mother is bringing to that child all the nutrients and minerals and core vitamins that they need in order to grow into a healthy child. The child is particularly vulnerable that first phase of development, which is the first trimester, because all those organs are forming. The types of fats the mother is eating, for example, is critical to neurological development. So simple, healthy fats, olive oils, those types of oils are really, really important with helping with appropriate development of the neuronal system. At the end of the day, we're a bunch of nerves. And if those nerves are not developed properly, it translates into difficulty functioning cognitively and physically. It often results in a lot of conditions that could have been avoided if the nutritional value of food the mom ingested during pregnancy were better. Taking things like over-the-counter medications that aren't safe. There is no safe amount of alcohol that is recommended during pregnancy, and alcohol causes a whole host of problems for the fetus, fetal alcohol syndrome, for which mental retardation, or I'm sorry, academic or developmental disabilities are the #1 cause. And also tobacco ingestion during pregnancy is also problematic to fetal development. Fetal development, last comment before I turn it over to Melanie, results in lifelong problems for the child and lifelong stress for the parents who love their child and want to maximize their ability to be okay in life. And so the issues pre-pregnancy, during pregnancy, after pregnancy that are nutritionally related are critical to understand as a part of maternal health, including maternal mental health. Melanie?
Yeah, and Dr. Dunham, thank you so much for that. And I just wanted to, since COVID, we have definitely seen numbers of families that are living with food insecurity increase, which means that we've also seen the number of pregnant women that are experiencing food insecurities increase. So throughout the US, it's about 10% of US households are considered food insecure. And when it comes to pregnant women, that number jumps nearly 20%. So we see that there's definitely a need to provide nutritional support. We see that, just from a practical standpoint with the families that we serve working through training grounds and the We Play Center, that we are getting more and more families looking for food banks, food distribution centers, places where they can get food. And so just being mindful that because nutrition plays such an important role in not only the mom's development, but also the child's development, we have to be able to connect our families to the variety of different resources that are available to them. So that they can get the food that they need. Also, just kind of some of the eating habits and things that we're eating that contributes to some of the high blood pressure and obesity. So if we're coming into pregnancy with some of these medical conditions, then it's only going to grow greater as they are going through their pregnancy. And so we just want to make certain that we are educating people prior to them having children and that pre-childbearing age, so that they're eating healthy and really kind of getting the nutritional things that they need in their bodies. So, one of the recommendations that we have seen and that we've been working with is how do we let that pre-childbearing group know about healthy eating habits? Like, we don't want to have them to start eating healthy once they're pregnant. We want this to be a lifestyle. We want them to come into it because we know if you come into pregnancy with these healthy lifestyles, then that's going to increase your chances of having healthier outcomes. So as we're talking about this, I know we're really talking about, that postpartum or pregnancy timeframe, but just really as we're thinking of solutions and, as a practitioner, someone that's actually out doing programs, I'm constantly thinking about what can we do to prevent problems from happening. And one is really focusing on those pre-childbearing groups, that age right before they become parents or start to think about becoming parents, and making certain that nutrition is really a big part of the education and outreach that we're doing.
Okay, wonderful. Well, our next topic is of immense significance. It's the intricate relationship between a mother's health during pregnancy and its profound impact on the developing fetus. Dr. Dunham, can you delve into the interplay between maternal well-being and fetal development, shedding light on how the physical environment of a pregnant mother can shape the course of life before birth and throughout the first years of life?
Yes, of course. And we've touched on some of this already because these things are all so interwoven. It's difficult to kind of separate them out. As you're seeing, we're commenting on multiple aspects of how that maternal environment is impactful to herself, as well as her child, as well as her children who are currently under her care. But specific to the fetus, again, the fetus is passively growing inside of the mother's body. And the placenta is the connecting cord that through which all the nutrients and everything that the mother experiences travels to the child and really nourishes the child. And that has an impact on the development of the child throughout the course of their developing phase. So taking in the right nutrients is one of the things we've already talked about. But what we have not talked about is the emotional environment that the mother is in, that the child is unveiled around. And so what do I mean by that? So let's talk about stress in particular. Stress is a beast. It really is. We really don't always comprehend the level of impact that being under stress has on our physical being as well as on our mental being. Now, we are consciously aware of stress when the stress settles as tension in our muscles and in our joints. And sometimes we will have physical problems that are complicated by stress, like muscular alignment problems, or actually just even use of our muscles on a daily basis, cramping, those types of things. But we often aren't consciously aware of the fact that internally, our internal organs are also being impacted by stress. Example of one of the biggest culprits to our internal metabolism is cortisol. So cortisol is a good and a bad thing. It's a hormone. Hormones are generally good. I mean, they're created for the purpose of being released and traveling through our bodies to impact the functionality of different organs. And a lot of our organs are under hormonal control. In the case of cortisol, cortisol is what's released when we are in any situation that is perceived as threatening. And its purpose is to increase our heart rate, increase our blood flow so that we can fight or flight. In other words, we can do whatever we need to do to protect ourselves. And it's an automatic thing. It's not something that we are necessarily consciously aware of because it's not under a conscious control. So cortisol levels increase during times where we need to be able to protect ourselves. Problem with cortisol, though, is sustained high levels of cortisol. Think about the fact that in an environment where an individual is not getting their basic needs met, the stress that puts them under chronically. So an insecure, food insecure environment, an environment that has domestic violence involved, an environment where children are having difficulties at school, mothers trying to work, trying to get adequate or gainful employment, but unable to keep the job because they have to go to school because of their children's needs, or they get sick and they don't have paid leave coverage with their jobs. All of this is very chronically stressful. And for Black and Brown people, it's complicated more by systemic discrimination and experiences that have nothing to do with them personally or in terms of their capability, but it has a lot to do with perceived ideas of that devalue them and make inequity a common practice. The constant overwhelming stress is constantly keeping the cortisol level at a level that the blood sugar rates are high, as well as the salt and water retention levels are high. And that results in very, very difficult hypertension to treat. It also is a major culprit in the development of diabetes and the complexities associated with diabetes because of those persistently high glucose levels. So it's like the body is always ready to fight or flight when it doesn't really need to. And yet the environment the person is in, the situation, socioeconomic situation, is so stressful that the person's body is responding in a way to protect itself by releasing cortisol and keeping those levels at a high enough rate that it's then impacting the overall metabolic situation as it relates to their blood sugar levels and their blood pressure levels. What does that do if a child's growing inside of that mother? That creates what we call preeclamptic environment, which is also predisposing the woman to seizures because of the high blood pressure. It predisposes the woman to gestational diabetes. A child growing in a diabetic environment as a fetus is more likely to be overweight and may have difficulties of their own. What else does that do to escape it? There's escapism through substances. Woman may more likely to smoke weed or to drink excessive amounts of alcohol to just escape. And that then is passed on to the fetus with complexities associated with neuronal development during that gestational period. And so on and so on and so on. So the fetus is never going to be separated from the mom's internal environment because that environment is created intentionally to take care of and bathe the fetus. And so we've got all sorts of complexity. Stress alone does all of that. That one thing, uncontrolled, out of control stress can do all of that. And then once the child is born, if the mother does not have capacity to take care of their child, even if it's just their perceived capacity to take care of their child in the way that they would like, that is persistence of stress postpartum, which continues to be impactful to her ability to manage her own life. And now she has a young dependent who may be one of several others that she's struggling to take care of. So stress and the internal environment, stress as an example, in an internal environment where a woman is pregnant is tremendously problematic for the child. Take home is whatever unhealthy behaviors the mother is experiencing, the child will vicariously be impacted by those experiences. And it may be a physical consequence, but it also often is cognitive or later emotional developmental problems for the child as well.
Yeah, and Dr. Dunham, the work that we do and that we see with children birth to 3, we really are experiencing parents that are experiencing a lot more stress during pregnancy and children that are being born into stressful environments. And it's kind of like this cyclical kind of experience that's happening, right? So children are born into, the parents are dealing with this stress, the children are feeling it, they're being born, and they have this sense of like, how do I survive? And it creates, some anxiety for the children. It creates this need to be almost in fight or flight from the time that they're born. And then it creates creates an environment where parents are now more stressed because they have children who are crying or children who are suffering some of these emotional experiences from birth. And then parents become more depressed and they become more anxious. And it's just kind of like this cycle. And so really getting people to understand that the parents' emotion is sending, especially in the 3rd trimester, those feelings that parents are experiencing, those high level of stress, that cortisol that is being released, the child is being shaped for what to expect in the future, right? And so this child it's kind of, and I'm always amazed, not being a doctor and not really into the science that way and being trained in that way. I'm just always amazed at how the body gives us exactly what it thinks we need based on the experiences. And so we see children that are being born almost with this sense of fight or flight from day one. And it's good if that's in the environment that they're in and they need that skill set. But what happens is that when they are born and maybe things are calm, financial situations are better, relationships are better, now you have these children who have been prepared this last trimester for this environment that now doesn't exist. So they're anxious, they're uncertain how to really survive in this calm environment. It's just amazing to me. And I think that more we can educate parents and the more that we start to help them understand that this concept of temperament is just not this magical thing that happens, but all of this is shaping who your child is going to be and how you choose to and how you're going to respond to your child and how your child's going to respond to you in the very early days. Could be a life changer, I think, for our community.
Absolutely. That's so beautifully stated, Melanie. And the word we use for that is epigenetics. Because epigenetics is where genetics, your genetic capability that is passed on to you, which is probably your highest potential, then meets environment, Environment has a huge impact on our genetic tone, and it then reshapes what our genetics would have been if it had been in a different environment. We do a lot of twin studies to bear that out. You take two identical twins whose genetic makeup is almost exactly the same. That's the closest you're going to get to that. And you have them grow up in different environments that are completely different. And then you see later what the outcome is. Now, this is not intentionally done on the front end because there's some ethics involved if you do that. But these are retrospective studies of what has happened where kids have grown up, different environments, same genetic loading, very different outcomes because of the impact of environment. That's epigenetics. What can we control there? We can control the environmental situation that the child is in order to create a better outcome. So that adaptive functioning is so very important for us to manipulate in a way that gives the child the best opportunity for health in this world.
And so just kind of understanding, if we know that women have been stressed and we know children have this heightened level of cortisone, then from day one, we need to be working to help that child adjust, family adjust, because we know what some of the negative outcomes are when children live under heightened levels of cortisone and what that does to their language, cognitive, their ability, their brain development. And so we don't need to wait until it starts to manifest itself at 5 years old. We can start literally day one that they're born to begin to help prevent negative outcomes for that particular family.
Yes.
And Melanie, can you please elaborate on the impact of environmental factors on maternal mental health in the children?
Yeah, I think that that's what we've been talking about this last cycle, right, Stacey? I mean, Susan, I think that the environment plays such an important role, whether or not that's a supportive environment that you're living in, if you're living in an environment where you have access to fresh fruits and vegetables, if you have access to a community of supportive, loving people, like we know those are all the things that's going to reduce your stress level. It's going to reduce the likelihood of you having any kind of experience with postpartum depression or anxiety. And so, yes, the environment is extremely important in how the pregnancy is handled, how the children are impacted. And I just want, from the environmental standpoint, a lot of times when we have these kinds of discussions, we talk about the negative part of the environment. And I just, as you notice, I started off really talking about like when these things are in place, when these things that we know, food security, health, making certain that all of those social determinants of health are addressed and that they're there and available for families. We see better outcomes for women. We see better weight and birth outcomes for children. We see the better developmental outcomes for children and less stressed families over time.
And I think, Melanie, what you're saying is that education is a big part of this, right? So when you all get your families into We Play Center, these are families often that are existing with high stress levels. In many cases, domestic violence or conflictual relationships that are not supportive. It could be relationships for generations in that family that have not been supported or healthy. So when they come into the door that this is a case that is very, very much available to needing to have some stress reduction work done. So education becomes so very, very important. I think very often people are categorized, and this is where the prejudicial thinking comes in that there are attitudes and beliefs around certain groups of people that they can't do any better, never will do any better, and there aren't efforts put in place to provide them with the same opportunities to do better. And so the thing I like about your center is that you assume on the front end that if we do all of this, you are going to be better, and you see results, right? When you do that. And so it is the classic example of how providing intervention work can really, really help people do better once they know better.
Right. And providing true wraparound supports, right? When you talk about environment, whether it's housing, whether it's food, whether it's jobs, like really, how do you bring in a family and provide them with all of those supports, so that during the pregnancy or immediately after the pregnancy, they have systems that are already in place to support them in the work in the direction that they're trying to go. We have to believe that every person wants what's best for their child and their family at the onset. So when they walk into your door, yes, they might be dealing with some issues that may be contradictory to what we might want to believe, but I've never met any parent that when they found out they were expecting, that their intention was to make really bad decisions and make life complicated for themselves and their children. That
Yeah.
just doesn't exist. I've never, and I've worked with hundreds of thousands of families over, these 25, 30 years. I've just never met a parent that when they found out that they were expecting, that they were going to intentionally eat bad food, that they were going to intentionally argue with their partner, that they were going to have all of these cortisones so that they can make life difficult for their child. And so we just have to continue to figure out ways to support families, and the desired outcomes that they want for themselves and their children as well.
Yeah, absolutely. I've seen the same thing. Even when you formalize that and do use the SBIRT model, which is screening, brief intervention, and referral for treatment. What we've seen with that model, where you screen, the person has risk factors, you provide them a very targeted evidence-based intervention. 60% or more of the time, people do better because they just know better. So you're absolutely right. That's very true.
Thank you.
Well, guys, let's take a pivot and talk more about one of life's most transformative journeys, pregnancy. I would like to extend our focus beyond the individual experience and discuss the broader impact of maternal mental health on families and the often overlooked aspect of paternal health care. Melanie, can you shed some light on how family dynamics can be impacted by pregnancy and the evolving role of fathers in ensuring a healthy start for their children?
Right. And I think just acknowledging and recognizing that having fathers involved and being involved from planning what delivery looks like, right? Oftentimes when parents show up to the initial doctor visit, so much attention is given to the pregnant partner. And so much attention is on, the pregnant person or the person that's going to be delivering is having the support they need. The other partner needs support as well, because they're going to be the rock for that person that is delivering. And we know that their mental health has to be stable and together so that they can provide the support that they need. It's kind of like you can't give from an empty cup. We have to make certain that we're pouring into the other partner so that that person can have the support they need. So yes, as I mentioned on the onset, that 1 in 10 fathers experience postpartum depression. And what that looks like may not be the same way that it looks for pregnant women. It may come out as anger. It may come out as being very withdrawn. You may even see them pull away because they don't think that they have the skill set or the knowledge to be the kind of father that they want. You might see in times where they become extremely concerned with money and finances, and they're working all the time and not providing the emotional support that the family has, because they're constantly worrying about how are they going to provide for their family. And so as they're going through this, whether it's during the pregnancy or immediately after the pregnancy, that can sometimes be perceived as if the father isn't interested or they don't want to be there, when in actuality, they are dealing with their own mental health issues and trying to come to grips with what does it really mean to provide for your family and support your family. So, going back and then that leads into different kinds of relationship issues. Then how do we support each other and they're not being there? And so what could have come from a very loving and supportive family, because we have this depression or anxiety that exists, it is now conflict and animosity and stress, which then contributes to the stress hormone levels for the mother, which then we just talked about what happens to the child as a result of high levels of cortisol. So we want to make certain that we're supporting the entire family. And when they're coming into your office spaces or coming in for services, that we are giving that other partner the kinds of supports and opportunities. A lot of times, we are screening the mother or the birthing parent, but we don't screen the other parent. And we know that that person's mental health is what's going to help support during these high stressful times and sleepless nights. So we want to make certain that we're screening both parents for any kind of anxiety or depression that might be existing as a result of just giving birth or becoming a new parent or a parent for a second or third time.
And Dr. Dunham, can you weigh in and explain how family and social dynamics are a factor in maternal mental health outcomes?
So the familial dyad, the interrelationship between members of a family is extremely significant because everybody has a role in the family. And there is this misperception that there is one way to be a family. And if you are not that way, then you will suffer more adversely. And that's not absolutely true. And I was glad that we were able to come across one study, it's a longitudinal study that looked at a comparison of households with two parents where the relationship between the parents was not good, and a household with a single parent where the relationship with the parent, and this is relative to the kids, relationship to the children was very good, and how those children fared in those two different environments. And as it turns out, the results of this study indicates that the ability of the child to do well or not is more directly related to the health of the relationships that they are growing up in their nuclear environment. And so what does that mean? That means single women can raise healthy children. They can. Now they need to definitely tap a village to get those other needs addressed that they can't, within their own limitations, help their child with. But that's true for a traditional family where you have two parents. Everybody needs to have a village to tap. But what children do not need is the internalization of unhealthy relationships between adults throughout their childhood, because that is a part of that epigenetic shaping that can ultimately result with them in them having neurodevelopmental disabilities from the perspective of not being able to execute good judgment, make good decisions, and function cognitively in a way that is so critical to success in life. The more we're able to think clearly, come up with good solutions, results, respond to situations and circumstances in logical, reasonable fashions is directly determined by a lot of the learning and internal imprinting that the people who have spent the most time around us have provided us. And in relationships that are not working in tandem, there's a lot of energy that is destructive in the home environment. The interface between the two people is destructive for those two people. That child learns that. That's what they learn. And of course, those aren't healthy coping mechanisms. And so the environment that we create as adults is always shaping how our young people are becoming. And if we have to create an environment where relationships are good and it's not a traditional family, then in the end, it's probably going to be better off for our kids. And so how we treat each other matters tremendously in terms of how children internalize how to treat themselves, as well as how to treat other people. And in the end, that is more likely to result in a happy young person who is productive and is able to give back to society. So we can't overlook the impact of relationships in all of this. It's not just about divorced homes. It's not just about a home being raised by two people who are homosexual or not heterosexual. It's not just about that. It really is about how are you in that home and how that child is perceiving how people and themselves ought to be in relationship with each other. So that stuff also, Melanie, that I would imagine that you work a lot on with your parents in terms of being able to be more empowered in their own environments, whether they are a single parent or not.
Yes, definitely making certain that they have a voice. And what we've done is actually partnered with some of our doulas in the city. I think that for those of you that may not have heard of doulas recently, that's kind of all we're talking about in maternal world because it is such an added support. But it really is a person who has the um, pregnant partner's best interest at heart, right? And helping them to have a voice from day one, whether it's planning how the delivery room is going to be, who's going to be there, helping them decide on their birthing plan and making certain that their birthing plan is followed through, providing support for the partner to be able to have a voice and feeling like they can actually carry out the birthing plan. And so for us, and when we're working directly with families that may be going through some of these challenges, we have worked with one of our community partners, Labor and Love, who has a nonprofit component to their doula services. And we're able to get doulas for families who otherwise would not be able to afford to have a doula. And the reason why I really like the doulas is because Dr. Dunham, like I said, it helps them to have their voices heard. Even if they aren't accustomed to advocating for themselves, they can kind of have this person that they can advocate for that will advocate on behalf. And we know that from research that has been done recently that there are better outcomes for Black and Brown women when there is a doula present, because that person's sole job is really to advocate on behalf of the parent and to make certain that the parent voices are heard. So I know just recently, private insurance companies in Louisiana have passed legislation that they are going to provide doulas. And so we know that normally when private insurances move in one direction, then we can generate interest and support for Medicaid families too also. So it's not there with Medicaid families yet, but we are hopeful because we see in private insurances that doulas are being covered. I want to say maybe up to $1,500 for the course of the pregnancy, which is really, really exciting news for us, those of us working in maternal health and child welfare.
And Dr. Dunham, can you discuss some strategies and recommendations that you think may enhance the mental well-being of new mothers?
Yeah, I actually, the concept of doulas is a great one, but it's more foreign in Black and Brown populations. It's also very expensive because it's not covered. So it's good to hear that it is being covered by private insurers, but with over 40% of our women on Medicaid, it doesn't really help them yet.
Not yet.
Hopeful that is going to move forward, because that's really kind of rolling back our history, because that was the arm of healthcare to help women, them and the equivalent of nurse midwives. And yet both of those two professional types are not reimbursable, nor are they very well known. I think more people looked at some data, and in the United States, we are like second from the bottom of the large countries that actually use midwives pretty effectively or aggressively in the care of obstetrics needs. We know that the obstetrics population is declining in terms of the number of OBs that are available to do hospital-based work. That reduction is at least 77% in the next 10 years, and we're expecting a 4% increase in need for obstetrics work. And it's worse in rural communities and in communities that predominantly provide services for Black and Brown people. And so these stats translate into actions that need to be taken, such as intentional efforts to promote development of doulas and get them the appropriate pay to do the work, and reimbursable rates. Also expanding schools that train midwives, but in our own profession as physicians, being more acceptant of other members of the team being as important in their capacity to helping with the situation that we're in. We don't have enough MDs to do any of the work we do for that matter. And so being able to have other sources to provide some of the services that are needed for individuals who frequent, in this case, an obstetrics practice is very helpful. I do know I have one good friend, she is an OBGYN. She doesn't do the OB side anymore. I think she's only doing the GYN side, which is usually what happens with OBGYNs after a while, just like ER docs. The intensity, the cortisol levels that they maintain most of the time in the practice of their trade eventually burns them out. And often they do retire into an aspect of their training that is far less intense in terms of stress. And so OBs often sunset, though people may continue the GYN component of their practice. So who is going to deliver the babies? Who's going to do the management? That's where the midwives come into place, and that's where the doula support is helpful. So even encouraging our young up-and-coming individuals, kids who are interested in health science careers, to consider these professions and allowing them to shadow people who do this work so they can get the real perspective on what this work looks like is really important. But making sure that the money works for the care and that the care is equally distributed throughout the environments that tend to not have appropriate access. Now, if you talk about stress, for post-traumatic stress disorder in particular, in women, high rates for the reasons we've been discussing. One of the things that we do at Metropolitan Human Services District is we have a special program where services that are provided in a 24-hour environment, the ones that we contract with, we have an LCSW and a team of counselors who go to that environment and they provide on-site support to those women. We also try to make sure that we're screening women for these conditions, because some of these things, particularly domestic violence, is not something that a person is going to necessarily be very forthcoming with unless you ask the right questions, because it's very embarrassing, not to mention the fact that it's a very dangerous situation for a woman to be in. And so who am I going to talk to about that without me having potentially dangerous repercussions? So understanding that, training people specifically in how to deal with those issues, which are often more prevalent, not exclusive to women, but more prevalent in women, is a very, very important part of some of what we have to do, particularly in our behavioral health settings. But there's a whole host. A lot of what Melanie and I have been talking about, or interventions at the person we're serving level, or at the level of the person who's presenting for the services. But there's a whole nother level of work that needs to be done at the institutional level, where we are finding that people who look a certain way are not treated fairly, nor are they treated equitably. And that results in people not going to healthcare providers because the trauma of the experience is too overwhelming than perhaps the pain that they're coming to that healthcare professional to address. And so our healthcare system is a part of the problem because there's not equity across the board in terms of services being available, and in some cases, how services are being provided. I'll give you an example. In one of the findings that we had in our research around this is that the 5 most common forms of maternal mistreatment reported by 1 of 6 women from doctors, nurses, or midwives. First of all, being shouted at or scolded. Secondly, being ignored or refused requests for help or didn't respond quickly enough. Third, violated physical privacy. Fourth, threatened to withhold treatment or forced a treatment the person didn't want. And 5, threatened in other ways. Who wants to see a healthcare professional who does that? Now, am I indicting all healthcare professionals? Absolutely not. But the guilty shall stand as charged. And so if that is the case, that is a problem. And many women may not have been treated in one of these ways, but many women have been treated in some of these ways. And so we do have to address the issue of mistreatment in the healthcare system that has a lot to do with not listening to women, not seeing them as credible or believable in their care. And this is not just perpetrated by people who are not women. This is also perpetrated by women with women patients. And so we have to do a much better job because there are systemic issues that go beyond the person. We have to change policies. We have to change the ways in which we're monitoring care. And we have to make greater efforts and strides at making our healthcare more equitable for women. Other thoughts about that, Mel?
Yeah, actually, Dr. Dunham, it's very in line with what we're seeing across the state of Louisiana. So March of Dimes, New Orleans, and Sister Midwife Production has been doing listening tours around the state for the last couple of years, collecting stories of women, Black and brown women, about their birthing experience. And those 5 that you touched on are the same 5 that they're seeing in the data that they're collecting about the birthing experience. And for so many women, how traumatic that experience has been. And we also see that it was regardless of income level, right? So we see women who are very affluent, very highly educated, who are saying that they have experienced those same kinds of interactions with the medical profession. So we want to make certain that as we continue to bring light to this, that we are educating everyone, not just the individuals, but also those that are serving the individuals. I would also say, in addition to the doulas, just making certain that if you're working with families, connecting them to resources, right? So understanding that nurse-family partnership will go into the home when the mother is expecting. Healthy Start is an option for pregnant women, regardless of income. You know, breastfeeding supports early on. I think for us at the We Play Center, because we do provide a breastfeeding support program on Tuesdays, we literally get to see families 2 weeks or 3 weeks after delivery. And we're able to talk with them about their mood and how they're feeling, and then make certain that we are doing screenings and then referring out if they need more, if it's not baby blues, but more on the depression or anxiety side. So just realizing and recognizing what those resources are in your community. We have a large number of them throughout the state of Louisiana, and connecting families to those resources and making certain, we just had legislation passed last year that pediatricians should be doing screenings on mothers when they come in for their wellness visit. Following through with those screenings and doing it. One of the things we talked about yesterday at the women's policy meeting was that there's a disconnect between policy and implementation. So we have policies on the books that are in really like for the betterment of our society, but then when we look at whether they're actually being implemented and followed through, there's a disconnect. So I would just challenge each and every one of you out there to not be part of that disconnect, but work really hard to make certain that our policies and our practices line up and match each other so that we can, kind of move away from the bottom part of the world when it talks about maternal mental health and birthing outcomes for our Black and brown women and all of our women in general, because in Louisiana, everyone is struggling. The numbers for Black and brown are just so much higher.
Exactly. And so the perinatal mood and anxiety disorders really are the single largest complication of pregnancy and childbirth. And there are a couple of key, just to summarize, key successful maternal mental health programs that are important to be aware of. Timely screening, assessment and intervention pre and postpartum is important. The other thing is integrating mental health throughout all aspects of care, because mental health is health. And we have to carry that message to people that if your mental health is not good, then it's very difficult for your physical health to be okay. And we all have good days and bad days, and some of us have more bad days than good days, and we really need interventions for that. Ask patients and families about the care they received. They are going to be the best informant to us about what their care has been like. And the purpose for that is not to have a nice conversation only, but it's also to make sure that we are learning what good care looks like from the perspective of what they're telling us was bad care. And so improving our systems based upon the trusted opinions of the people we're serving. And then offer certified training on mental health to support providers. We do need to expand the interest of the provider pool to do mental health services. Mental health professionals tend to be underpaid. Mental health professionals also tend to not be glorified in terms of the heroic work that is done by the mental health community. We treat people who suffer with one of the greatest stigmas in healthcare, and it's not just about seeing them sitting in front of us. Often it's about going to get them, to help them to come to see us so that we can get them the help that they need. And so it's very difficult doing this work, and it does deserve the appropriate compensation as a result. And then creating a culture of mental health awareness and support. That is so, so very important. That begins with being able to acknowledge that you're having a bad mental health day and you need a break. But that's true for anybody. Anybody can have difficulty, but we're talking about people whose most days are problematic from a psychological or psychiatric perspective. And so being able to put the message out there that mental health is health and that prevention works and that we really want to do everything we can to destigmatize mental health so that people feel comfortable getting the support that they need. And some of the challenges we've talked about was connecting people with adequate mental health resources. Licensed professionals will never be enough to do this work. There's a component of this work that requires the community to be better educated so that they can understand how to manage the situation in their own home. There are things that happen that escalate to the point of having to bring in licensed professionals. But if we have preventative strategies in place, like mental health first aid, for example, where we can teach people what to do, what to say, how to respond in a crisis, it will never have to come to us, and adverse events will be prevented. Address stigma associated with mental illness and treatment. Again, can't say that enough, that is probably one of the #1 reasons why people don't show their face if they have a mental illness. It's certainly one of the main reasons why we could never get a whole lot of support at the Capitol on bills that require testimonials from people who are experiencing the problems. So the mental health community has to also help do some of this work to advocate for themselves with those of us who are committed to helping them. And then we have to offer virtual services, integrating mental health in all care settings. There are questions that every healthcare provider should be asking in order to identify the people who, in most cases, are in other healthcare systems, not the behavioral health system, seeking help and are experiencing problems that are treatable. But nobody asked. Nobody asks if I'm having trouble sleeping, if I'm having more bad days and good days, if I think about hurting myself, if I think about hurting other people, if I hear voices, see things, or don't understand quite, and my memory is going down the drain. Nobody's asking those questions. Those questions have to be asked. And then establishing support groups for patients and families, because we know that self-help works. It is the largest savior in the addiction world. A person who has a problem with a substance helping another person with the problem. Community health workers are extremely important there because they are people who are trained as peers, the equivalent of peers in the primary care setting, as peers are people with lived experience in our setting. But providing support groups, making space for those individuals to meet in our businesses and in our hospitals and so forth, but also creating support groups in our own environments. OBs need to have support groups for postpartum women to make sure that they are supported during that period. Pregnant women need support groups. Women need support groups. There are just a lot of issues that we are struggling with as a society that you need somebody else to hear it and bounce it off of. It's just very difficult to manage alone. And so these are some of the things that we want to promote. Of course, we can go on, and this conversation can go on, but we want to allow the audience some interface with us and to continue the dialogue. So thank you all for tuning in.
Thank you, Dr. Dunham and Melanie, for sharing your insights and your expertise on the subject. We applaud your valuable input. I'm going to hand it over now to Stephanie to moderate the question and answer portion from the audience.
Thank you so much, Susan. And thank you, Dr. Dunham and Melanie Richardson. It's been so educational and interesting to hear everything that's going on in this space. And so rewarding, I think, as a woman, that we are now having these dialogues and acknowledging that that it really, all these social determinants of health really do affect our mental health, and mental health is health, as you said, Dr. Dunham. That's certainly something at Louisiana Mental Health Association that that we say all the time as well. One thing that I wanted to do, both of you ladies referenced the type of services that you provide specifically for this population, maternal mental health and after, but if you could just list those out for us so that people who are listening to the program know exactly what they can expect and what they can come to you for.
So Melanie,
I'll start. So Training Grounds and the We Play Center. So we offer a class that's called Hug Your Baby that is offered the third and what we call the fourth trimester, which allows parents to talk to a trained professional and learn about the cues and what to expect when they give birth to the child. But also during that time, we're able to pick up on whether or not the parent has experienced any extra anxiety above the normal, I'm about to deliver in a couple of weeks, right? And if we're able to identify those, then we can do screenings and then we can get them the support that they need so that when the baby is delivered, that they already have those support systems in line. So that's our Hug Your Baby, class that we offer. We also do breastfeeding support, which allows us to see the parents within the first 2 or 3 weeks of after delivering. Because most times, most people don't get to see them 2 or 3 weeks, right? They don't go back to the wellness visit until 6 weeks. And this allows us to put eyes on them to make certain that they are, feeling okay. If they're experiencing baby blues, we can talk to them about the difference between baby blues and postpartum depression. And like I said, once again, do screenings and get them the support they need. And then because we know that a lot of times postpartum depression can last within that first year, through the We Play Center itself, parents are able to come with their children during that first year. And because we have parenting educators on the floor supporting parents and coaching parents, we're able to pick up on mood changes. We're able to pick up on whether they're getting enough rest or sleeping, and just really have organic conversations with them and normalize some of the feelings so that we can get to the root cause of it. And if we realize once again that there is something more there, we've already established a relationship with them, that we can encourage them to have screenings. Our We Play Center director is a licensed clinical social worker. And so she has the ability and the skill set to be able to do extra screenings and really make those referrals in a clinical way so that it's not just, anecdotally or just because we think something. I mean, so she has those skills. And so I would say that of all the programs that we do, our Hug Your Baby, our breastfeeding support, and the We Play Center. And I'm going to put a plug out with Dr. Dunham as well, because we actually have a partnership. So we have women that may be receiving mental health services through Metropolitan can actually come to the We Play Center, and we work together to make certain that they are connecting, bonding with their children, having that positive bonding and attachment, and are able to talk back with their clinical support team at Metropolitan to make certain that we're putting our arms around them, right? So we know that it affects attachment and bonding when parents are having mental health issues. And so this is just another way to support the parent to help create those kinds of environments. And then they can get transportation and we continue to kind of work together. And I think that that's one of the things that I'd like to leave everyone with is like, how do we go outside of our own silos and figure out ways to work together so that we can provide the support? Because what we do with building that bonding and attachment doesn't necessarily happen directly in clinical treatment, right? They're getting the services and they're creating an opportunity for them to be more open to it, but then we create an opportunity for them to actually do it with the support of parenting educators, and reducing some of that stress. So I really admire and respect Dr. Dunham for being one of those that are out the box thinkers and looking for community partners to partner with.
So I mean, I can't say enough about it. I mean, we can't do what we do to completion without them doing what they're doing. And Melanie is absolutely right. You have to think beyond you. But you also have to be willing to go the distance, because the basic rubric for how to do this work is just that, it's basic. And if you really want to have any flavor added and get outcomes that really, really are impactful to people's lives, you got to roll up your sleeves and really kind of be more innovative and think through how to maximize on what's available out there and push for more. And so that's what we're always trying to do. I mean, those of you who know or don't know, we're one of 10 local governing entities tasked with the responsibility for addiction, mental illness, and intellectual and developmental disability services, which are also a huge component of what happens too in this whole dynamic of mental illness or maternal mental health, which we cannot ignore. And so we care for individuals who fall in one of those categories and the families that support them. But it is the indigent, uninsured, and over 90% of the people we see are Medicaid persons who have the limitations, the complexities, the challenges that comes with the economics of being qualified to receive Medicaid. And so we do that work in collaboration with others, not just with us, even though we're the largest provider of behavioral health services, even though we are the mental health authority for the state, for this area, we are not naive enough or arrogant enough to think that we can do this without others. And so we work hand in hand, we hand off, we take in. We do have some special programs for women because part of our funding, our federal block grant funding, requires that we prioritize addiction treatment for women with dependent children who have a substance use disorder, women who have individual IV drug use, as well as women who are suffering with, those are the two groups for women, but any woman who is suffering with a primary psychiatric condition, we try to prioritize. I need to tell you though that we could see a lot more women, but we do understand that stigma is a big factor. Childcare is a barrier, which is why the availability of telehealth has been very, very helpful. But for women, making decisions to get help is difficult because we're often so busy deciding how to take care of somebody else. We're not thinking about how to take care of ourselves. And so my imploring to women listening is that we got to do us. We've got to take care of us because we really are holding this thing up, ladies, but it's going to crash on top of us. It is crashing on top of us because we are not doing the best job of taking care of ourselves. So MHSD is here for you. And we certainly are available to create as much as we can what we aren't doing, if that will better serve you.
Thank you. And you're so right. It's so easy as a woman to put ourselves at the bottom of the list for care instead of, and the numbers bear that out across the board, both in the physical and mental health. And I also want to just mention that there is a national hotline for maternal mental health. It's 1-833-TLC MAMA, MAMA. So 1-833-TLC MAMA, and that's a place that that you can call if you have maternal mental health questions, and you're not quite ready to go see one of these magnificent ladies and the programs that they do, and that can empower you to do so. Is talking to somebody through that hotline. We do.
I would also say, I don't mean to interrupt, but since you mentioned that number, it reminded me of 988. Right. And I don't know if you want to mention that, the 988 number, but the 988 number is the behavioral health corollary to 911. So if you are having a crisis and you're not ready to come in physically, then you can certainly call 988. And the people who are answering those calls are people like us who are trained to have the right conversation, to listen, to be respectful, and to be able to think through what the needs are, and then to activate a process that gets you the help that you need. So we suggest that you write down 988. You want to write a few more numbers. Metropolitan's number is 504-568-3130. That is our window into the world of MHSD. And so you just need to call that number and present yourself and your needs. We have a crisis team that is first up. And if it's not a crisis, we have staff who are available to see you in an appointment, and then ongoing indefinitely, so that you are able to function better. And that's for anybody age 0 to 65 years old.
Thank you for mentioning 988. Not only is 988, it's a national number, and it will soon be on our driver's license. Thank you, Senator Bernard, for that legislation this past year. But it's locally answered for the most part, unless that line gets overwhelmed. And I think that's so important because there's a familiarity with Louisiana and our culture, and our internal issues, and the fact that we're not a Medicaid expansion state, and various things that impact Louisiana in particular. So I think 988 is just a great resource for people. I do have one question in here, and it says, are there any studies related to increased stress and preeclampsia?
Absolutely. I mean, and it's still the old cortisol story, because what cortisol does, well, the stress elevates cortisol. That's the chemical reaction physiologically in your body that happens when you're under stress. And remember, when we are stressed, our mind is thinking, I need to do something with all of this tension that I'm carrying. And one of the things that the body does is release cortisol. And then cortisol, though, gives us the right amount of energy to respond, to take care of ourselves. But the consistent or the persistent elevation in that amount of cortisol results in a prolonged experience of elevation in our blood pressure. And if that's happening while a woman is pregnant, then it predisposes her to preeclampsia, which is hypertension in a gestational state that can also be associated with seizures. And you can only imagine what a woman seizing does to a child who is she's pregnant with. So yeah, stress is absolutely related to preeclampsia through that mechanism that I'm sharing with you.
It's such a complex process. We are coming to the end of our time together, but I have one quick question, and then I'm going to give both of y'all just an opportunity to kind of wrap it home. I myself was pregnant a couple of times with my children, and both I gained a whole lot of weight with the children, and I now know, looking back, they're out of college, that a lot of that was my mental health, but no one asked me that question at any of my doctor's appointments. No one. Are you seeing those conversations beginning to happen in practices? Are we still the same as it was 25 years ago, where it's just, as long as your vitals are okay, no one's asking the other questions?
I think more it's being asked. I guess my issue with what's happening is that it's still very limited, though. Not just limited in terms of number of people asking the questions, though more people are, and there may be some certification criteria or even licensing criteria that requires a broader set of questions. So the promotion of mental health and physical health, both on the screening and treatment side, is advancing and is more prevalent than it was 20 years ago. But the types of questions that are being asked are still very, very limited. So the PHQ-9, which you will hear about, is what you're more likely to be asked about, and that's specific to mood disorders. But mood disorders are only one of 4 categories of psychiatric complexities, right? So the GAD is more specific screener for anxiety spectrum disorder. So some agencies are adding that. But I still am not hearing anybody asking about psychotic disorders. Are you having any odd, unusual, strange experiences? Cognitive disorders are not necessarily being evaluated very well. And substance use disorders, so as an addictionologist, I will tell you that if you don't get everybody to give a urine sample, you're going to be missing it most of the time. So it is very important that urine testing for illicit substances and for prescribed substances become a routine thing that we do in healthcare, because especially now with people taking products illicitly, thinking they're getting one thing and they're not, and often not even knowing what they have ingested. And nobody will ever know because nobody is really looking at that. And so we as healthcare professionals have to get away from, if I know I have to do something about it and I don't know what to do about it, do the right thing is what I say. And then figure out before you do that, who you're going to call in case of these things. So prevention is always the best strategy. So I think improvement I've seen, but we still got a ways to go. What are you seeing, Mel, on your side?
Yeah, so when we definitely see parents are talking about it more, right? They are having more conversations about it. It's not, I mean, in a baby cafe circle where parents are talking, they're talking about their mood and whether they're getting enough rest or whether or not they've felt sad. And then other people are bringing that bringing it to the attention of the staff, and like, you know what, she's not been the same. So I think that there's more talk about it. I guess my biggest concern is that as we talk about it more and we're doing more screening, we still don't have enough support for people to really receive the help that they need now that we're talking about it and that we're doing more screenings, right? So if we're looking for someone to refer a person to, we still have a very limited number of physicians that understand postpartum depression and is working specifically in that field. So, but you know, that's kind of how we go, right? We have to get people talking about it. We have to get screenings. We have to get people there. And we have to then find and make certain that we have qualified providers to really help them through.
Yeah. Amazingly, we've just had the first specific medicine pharmacological, not going to come out with that right term, Dr. Dunham, I'll depend on you, but Sage Therapeutics came out with something specific for depression, postpartum depression. And this is the first one of its kind out. And it's amazing to me that we're in 2023 and just getting something that is specific to that. And I think that tells a lot of this story. In the last minute, ladies, is there anything that you would like to share? And thank you again, all of the participants and our panelists. It's just been an incredible conversation today. And we're so grateful that you took the time to share your expertise and have this dialogue with us.
I know that there's one question, Flint Mitchell had a question, and so I'll end by answering that question, right? What could we do to decrease the percentage of people dealing with postpartum depression? And I would say the same thing that we can do to help decrease people dealing with depression overall. We need to talk about it. We need to let people know that it's okay to bring their feelings and feel what they feel and bring that to the table. And we need to just make certain that we are creating environments where people feel safe enough to be able to talk about the struggles that they're having without feeling like they're going to be judged or that they're going to have their child taken away from them, or, you know, like all of those fears as to why people won't talk about their feelings and thoughts. I think that we just need to continue to create an environment where mental health is a priority for all families and all people.
Yeah, I would say the destigmatizing is the key. We can't get rid of the experience any more than we can get rid of people having diabetes and hypertension. It is a health condition that people sometimes, because of all of the hormonal imbalances that occur during pregnancy and post-pregnancy, that some people are going to wind up on the lower spectrum of mood stabilization. That's fine. It just needs to be acknowledged and treated, and it is treatable. And so really destigmatizing the experience, the human experience of mental complications is the most important thing. Once we do that, then we'll have more people gravitating towards helping people and more people coming into care, and we can kind of figure it out better as a collective. But I will say that it's so important for women to own their own responsibility for their health and to not relegate that to any system or any other person. We have got to be our own advocates. And for those of us who have some authority in these areas, that we maximize on the ability we have to advocate for others who don't.
Thank you. What a great way to end. Again, we gave lots of numbers out for people who they're going to flash up my email if you have other questions, and I can direct them to the panelists on our website, www.louisianamha.org. We have a screening for postpartum depression if you'd like to take that, or you want to send it on to somebody else. Again, thank you, ladies. Thank you, everybody, for your time. Enjoy the rest of your day and be healthy.
Thank
Bye.
you.
Bye-bye. They're gonna do a post. Is everybody off? Are you all?
I'm still here.